Thanks a million, Fiona. Obviously, hopefully, good at menopause, dreadful at technology. So I can only apologize for the delay in getting started. It's 100% my fault.
No problem.
But anyway,
not at all. No problem. No problem at all.
So,
Can you see the slides?
I can see the slides. All is good. Yeah, I know them like the back of my hand at this point anyway, I think. But so look, I'm delighted to be here. I think it is obviously a topic that I'm really passionate about and has obviously got great attention in the last couple of years. But we might as well crack on to the bit that's kind of interesting, I think, for people. So they're just my that's my background there on the slide there. So we'll go on to the next slide, and I'll give you a little introduction and a bit of history. So I'm not going to dwell too much on this kind of thing because, again, it's not really what people are here to listen to. But I just think to set the scene a little bit, the take-home point from this is really that women's health is an area that has been long ignored and has been treated in a very dismissive way. It's a huge part of why I'm passionate about what we do and why I love, you know, the kind of development of these dedicated women's clinics that I think are starting to pop up around the place, which is great to see. And just of note, as you can see, the word hysteria actually comes from the Greek word for uterus. The Greeks used to believe that when a woman had any mental health issues or any other maladies, that it was actually her uterus migrating around her body, which is just a horrific mental image for anyone, and obviously quite far off the truth, thank God. Okay, we'll rock on then to the next slide, if that's okay. So what is menopause? So as Fiona pointed out, the average age of menopause is about 51. And the term menopause is really just a medical terminology for your final period. Menarche is your first period, menopause is your last. And then we have other terms. So we have perimenopause, which is the few years, although it depends on the person how long that period of time is, but a few years typically in the lead up to your final period, when we see some hormonal change happen. And a woman is postmenopausal if she's had a full year with no bleeding for no other cause like pregnancy or medication. Okay. So typically menopause happens because our ovaries stop functioning. So really, although we talk about menopause as being the important thing, losing menstruation is actually not the important part of this. It's the fact that your ovaries stop ovulating and you stop producing, in particular, a really important hormone called estrogen from your ovaries. And that's what creates the symptoms. So we do see this happening in women at a younger age in a small percentage of the population. So about 1% of the population will have their ovaries will stop working or functioning appropriately under the age of 40. That's about 1%, and about 5% of women under the age of 45 will have this happen. Women who've had their ovaries removed, women who've had chemotherapy, radiotherapy, some medications, that can all induce essentially a lack of function from your ovaries, and then due to genetics. So some women go into early menopause because they've just inherited a predisposition. I'm very firmly trying to avoid using the word ovarian failure. There's a famous Canadian gynecologist who talks about how we don't apply the word failure to men. So we'd say ovarian failure, but we don't say that erectile dysfunction is penile failure, which I think is a really good point. So we won't say that. Okay, next slide, please. So perimenopause. So this is an area that's quite, it's relatively modern. So if you go back, like when I was in medical school, we would have learned that what menopause was and that kind of thing, but perimenopause just wasn't discussed at all. I lived in Canada and worked there for a little while, and it was actually the North Americans that really started to research and talk about and treat perimenopause. And actually, interestingly, a lot of that research then, out of a lot of that research, we learned that most women are at their most symptomatic through perimenopause. So on average, maybe age of about 45, but huge variation to that. It really depends on the person. We'll start to see some hormonal fluctuation. So it's not that you're not producing hormones anymore, it's that you're producing them in a much wider range. So lower at times and higher at other times, and lots of peaks or spikes of estrogen happening during that time. And that big sort of up and down fluctuation that happens with perimenopause, that's what drives those symptoms. And typically people, well, it can be really subtle, actually. So it can just be worsening of normal PMS for a lot of women. And then for others, we can see things like changes in mood, and actually cognitive function, or what a lot of people call brain fog, actually peaks through perimenopause. So most women find they're actually their most symptomatic at this time. And it's fluctuating hormonal production, lots of PMS type symptoms. And for some, it's very profound mood or cognitive changes. So we go to the next one. And I've just given some quotes there from real women. So strangely enough, I suppose we spend a lot of time of talking about menopause and how it's, it's low estrogen or estrogen deficiency, and that's sort of true once your periods have stopped. But that lead up to it, it is actually, you're probably overproducing estrogen a lot of the time. It's your brain and your body's way of trying to correct the slow sort of dropping off of follicular function in your ovaries. And so your estrogen levels don't actually drop until you're much closer to your last period. So I just think that's an interesting point to know. And it does feel like a bit like a roller coaster for a lot of women. The fact that those symptoms can come and go, so you can have a few bad months followed by a couple of good months, things could settle down completely for a few months, makes women often doubt what they're going through. It leads to maybe some of the medical gaslighting that we see, because there's symptoms that do wax and wane. So it's just important to recognize that. Okay. So when we say symptoms, what are we talking about? So the ones that most people are aware of and familiar with would be a change in menstrual cycle pattern. Now in perimenopause, what we're talking about there is a change of more than 7 days. So that could be either more frequent or further apart in terms of your periods, but more than 7 days from your typical pattern. So if you have a 28-day cycle, anything from, I'm starting to get periods now every 3 weeks, or 35 days or whatever. Vasomotor symptoms is the medical term we give for hot flushes and night sweats. We'll come back more on that later. I suppose we come back to that, and we can just go on to the next little bit of that slide there now. But there are other symptoms that are maybe less recognized. I'm, again, sort of passionate about the cognitive symptoms because I think they're some of the most debilitating symptoms, and I really think they're quite distressing for some women. Not everybody gets them, but probably 80% of women will have some degree of change in their memory or their verbal fluency. So finding words is one thing that we hear a lot about, and that's borne out in research as well, that women tend to have this issue with finding names or words of things. And then short-term memory, so integrating new information. And interestingly, there are symptoms that actually, with no intervention, no HRT, and nothing at all, tend to come back to baseline. So they tend to get better over time if we leave women alone. But that timeline could be anything from a year to a decade. And that's really significant. And then obviously a lot of women will talk about, I feel like I'm getting dementia. I feel like I'm developing Alzheimer's dementia. And that's really distressing. Our dog is just run in, so it's just joining our meeting here in the background. So those symptoms can be really distressing, but in particular, if you're trying to work, obviously in terms of functioning in your workplace, that's something to take into account. And it drives an awful lot of the loss of confidence that we see happen women at this time in their life as well. Connell, my love, 1 second. Other symptoms, joint aches and pains. Estrogen is a very weak anti-inflammatory. And I think that's probably why we see this kind of occurrence of these generalized joint aches and pains for women. Bladder issues, vaginal dryness, low libido, all really common too. I think the emotional, psychological symptoms people are quite familiar with. It can actually be the first time in someone's life that they experience really severe anxiety that can really take you, by surprise, almost if you haven't had that symptom before. That list is a drop in, it really could be 10 times longer than it is here. This burning tongue and burning feet and itchy crawly skin, which is called formication. There's a whole host of other symptoms, but they're highly individual. And I think I'm really just trying to demonstrate how broad these symptoms are. Okay, I won't spend too long on this because we've kind of covered it, but hot flushes and night sweats are very real. They're actually measurable. You can do skin conductance on people and you can actually measure them. They're associated with a few different things. So we know women who get worse hot flushes and night sweats actually often report the worst cognitive changes. And there is some research that would associate having worse hot flushes and night sweats with worse cardiovascular outcomes. So someone's heart disease risk might be slightly higher if there's someone who equally experiences bad hot flushes and night sweats. One take-home point with these is that they're really, really treatable. So there is no reason for anyone to have hot flushes or night sweats because we have really good medication, both hormonal and non-hormonal, to manage them. And in a nutshell, what's happening is your thermostat, which is housed in your hypothalamus in your brain, it is responding to these changes in estrogen by narrowing the zone of your core body temperature that it's happy with. And essentially, if your body temperature creeps up at all, your brain panics, decides it has to cool you down. And it does that by making all your blood vessels, rush to the surface to kind of dissipate that heat. It makes you sweat to lose heat. you get this horrible sensation. A lot of women get palpitations or anxiety with hot flushes, and obviously they can happen at nighttime too, and so you wake up an awful lot with them. And then they're immediately followed for most women by feeling really cold, because your body has managed to drop your core body temperature, which is what it was trying to do. Really unpleasant. And we'll just move on. Yeah. So I like to get this in nice and early because I think it is so important. So, so vaginal symptoms, again, really almost universal. Probably more than 80% of women will experience some changes. Again, this could be a topic like all on its own. You could go into the details of it, but in a nutshell, the loss of estrogen. So this is a symptom that some women will get before their periods stop, but the majority do not experience this until their periods are very spaced out or finished. And typically that loss of estrogen has a kind of knock-on effect in a few different areas. It changes the pH in the vaginal canal. So we get all these different bacteria that now live there, because it's like, I suppose, changing the soil in the garden a little bit. And so that's a horrible analogy that I instantly regret, but you get what I'm trying to say. So if you change the underlying pH, you're promoting some bacteria to grow more. They like the pH than others, than other bacteria. That's important because one of the things that women commonly experience is an increase in the number of urine infections they get. And some of that is because E. coli didn't like living in the vaginal canal before, but now finds it easier to colonize that area because of that change in pH. The vaginal tissue becomes thinner, less lubricated, drier, more friable. It shrinks a little. So the actual vaginal canal will shrink. Your urethra can even shrink a little bit. Your bladder is covered in estrogen receptors because embryonically it comes from the same tissue as your vaginal canal, and then it sort of differentiates. So they're all kind of from the one, they're all covered in estrogen receptors. So painful sex, dryness, itchiness, bladder symptoms like peeing frequently, recurrent urine infections, all really common. And similar to hot flushes, and I cannot stress this enough, this is a treatable symptom. No one should have vaginal dryness. Like the vast majority of women experiencing this, we can treat. And compared to hot flushes, so if we leave someone untreated, no HRT, no other intervention, most women with hot flushes, their brain will adapt. So over time, their brain starts to get sort of used to this new hormonal environment, and their hot flushes will go away. 5 to 7 years on average, but it does get better. But it's very different with any kind of vaginal or urethral or bladder symptoms. They just get worse for life. So it's really important that they're treated. Okay. And then just a note, like, and again, obviously with menopause, we kind of spend a lot of time talking about people not having periods, but actually in perimenopause, your poor ovaries, they're so overstimulated by your brain as it's trying to kind of wring out the last of your ovarian function that we see an awful lot of bleeding happening. So periods can get quite frequent and periods can get really heavy. Doesn't happen to everyone, but if it happens, you don't ignore it. Like, you know, it can have a cumulative effect on your iron level and fatigue and your ability to play sports, and like all the way to the extreme of women who can't, in terms of work, like, you know, I have to bring 2 changes of clothes with me into work, or I don't have anywhere I can change properly in private, or so, you know, it's something to not be scared to talk about, because we have excellent intervention, and you know, we'll often investigate it, and sometimes we find nothing and we can just treat the symptom. And again, there's really no one who should be suffering with really heavy, debilitating periods. So it's definitely something to talk about if you're experiencing that. And so different options, obviously, but we'll go on to the next slide, I think. Okay, so mood and emotional symptoms. So, you know, really common, like really, really common. And I think it's important to differentiate. You can have changes in your mood that are related to hormonal change. And for other women, they experience clinical depression or generalized anxiety that happens to happen at the same time as their menopause. And you're about 2 to 3 times more likely to be diagnosed with depression or anxiety going through menopause as other points in your life, which is really interesting. Obviously, it has huge impact on many different kind of factors or many different facets of our lives. Women who have a history of postnatal depression or anxiety, a history of very bad PMS, actually, women with really bad hot flushes and night sweats. These are women who are probably at increased risk, who we really should have a conversation with about how their mood is. Sleep, I think, is quite connected to this too. And really poor sleep can have a really big impact on mood too. So again, just really important to have the discussion if it's bothering you. I won't But I'll kind of skip over this a little because I think Fiona made a really good, discussion about this. But essentially, I think the take-home message is it is really important in the workplace because women are really important in the workplace, and all women living long enough will go through menopause. And there's a ton of research out there supporting this fact and supporting the fact that women often, for whatever reason, whether it's mood and emotional symptoms, physical symptoms, a loss of confidence, all these things that we know are connected to hormonal change, albeit temporarily, that it has an impact on how they function in the workplace, and that all you have to do is support them. Like, it's not that difficult, and you have a fully functioning, fantastic workplace again. So just it's worth highlighting, I think. And there's various reasons maybe for why this, this has been a long time coming and why menopause is considered taboo. And I'll try and not get on my soapbox about it. But one of the big things I think is the anti-aging bias that we have, and the kind of, and I think there's a gender bias there too. I don't think men fight the same anti-aging that women do. And people associate menopause with aging, and I think that's a huge part of it. But there's lots of other reasons too, and people don't want to be stigmatized. They might not recognize some of their symptoms. That's a really important one, because you can have I could have two women walk into my clinic, one after another, and they just have two totally different sets of symptoms. Like, they've nothing in common other than maybe, their periods have changed or something like that. But other than that, it's affecting them in two totally different ways. That lack of kind of empathy, can make it really difficult, and actually can make menopause extremely lonely for women at times. We'll move on. Okay, so we've talked a lot about symptoms. We've talked about how it impacts women on a kind of functional basis and day-to-day basis and in the workplace, but there is a health aspect to this too. There's like you can see the pictures there, obviously there's a brain element, which is quite controversial. But we know that there's definitely cardiovascular change that happens to women with the loss of estrogen. And we know that there is bone density changes that happen with the loss of estrogen. And actually, we might move to the next slide, because I think I go through that in a bit more detail. So with this loss of estrogen, your blood vessels lose some of their flexibility. So they become a bit more rigid, and that really promotes the development of plaque and like blockages building up in the blood vessels, and not just in your blood vessels and your heart, but also in your brain. So vascular dementia starts to climb, things like hypertension, so high blood pressure. Genetically, around this time, we often start making more cholesterol as well, and we can see that go up. There is some research that is ongoing now. It's controversial, as I say, but there's certainly thinking that with the loss of estrogen, we start to see plaque, a thing called beta amyloid plaque developing in the brain. And this is a risk factor for then going on to develop Alzheimer's dementia. Women are about twice as likely to be diagnosed with Alzheimer's dementia than men. But what's really interesting about that research, and what is kind of relatively new in that research, but not really previously historically known, is that those changes seem to happen for most women early in perimenopause. And up until relatively recently, we had believed that those changes happen really around the time of your period stopping and onwards, when you were kind of truly estrogen deficient, if you want to call it that. But now they know those fluctuating estrogen patterns, your brain is so sensitive to them that changes for Alzheimer's dementia probably happen much earlier. The loss of bone density is really important too, and it's a really unsexy part of medicine, if I'm honest, and people don't pay it an awful lot of attention. But if you look at the statistics around osteoporosis, they're frankly staggering. So like at least 50% of women will have bone density loss to some degree over the age of 50. So 1 in every 2 women over the age of 50 has some loss of bone density, and half of them will then go on to develop some sort of fracture or morbidity, as in a loss of function or chronic pain or a fracture or whatever it might be, because of that bone density loss. And we can treat it. So it's quite frustrating to see these statistics and see the impact that it has on people's health, and know that we've interventions then help and wonder why those two things haven't really been joined up. And estrogen is a huge part of this. So you lose about 2% of your bone density per year from the time of your final period onwards for about 5 years. It's 2% per year for 5 years. Now, after that 5 years, so 5 years after your last period, it does slow down. It's about 1% per year after that, but it doesn't plateau. So you just continue to lose bone density. And these are it's something that we should be talking to younger women about, because if you've really good peak bone density in your 30s and 40s, you have a bit of breathing space to lose a bit of bone without dipping into osteoporosis. In saying that, one of my pet peeves in medicine is that we make everything the patient's fault. And actually about 80% of your bone density is genetics. So you can only really work with the other 20%. You can only influence that. But look, it's better than nothing is the way I look at it. And at least if you know that in advance, you know, we can help people get bone density scans or DEXA scans or whatever that might help early on. Okay, we'll move on. Yeah, so controversial, as I say, in terms of estrogen's impact on the brain, and lots of research done and probably lots of research to do in this area. I love being able to tell women that the cognitive changes that they're experiencing are transient and will probably get better and back to baseline with time, and that they're not developing dementia more than likely, and there's huge reassurance in that. In terms of HRT's impact on dementia, I get asked that really frequently. We have several large studies that show introducing estrogen may increase the risk of dementia, which is not what the media has portrayed in the last couple of years, I feel. But we question a lot of that research because they've used older fashioned types of HRT. And then when they're looking at dementia, they haven't really differentiated vascular from Parkinson's, from Alzheimer's, from Lewy body, like all the different types of dementia that we know exist. So it's a bit of a sweeping statement, and it's hard to really counsel women based on something so broad. And the other thing that we're kind of learning more about is about introducing HRT or estrogen early to know what impact that might have on risk. So before your periods stop. There is a suspicion. So two things. One is that if we introduce estrogen early for women at high risk, we may reduce their dementia risk. But that research, there's still a large question mark. So I wouldn't ever recommend that someone starts HRT to reduce dementia risk. That's not what we use it for. But the other interesting thing is that sleep and hot flushes and night sweats. So there's other research pointing towards the women that if we treat their hot flushes and night sweats, if they get bad hot flushes and night sweats and we treat them, we may protect their brain in doing so. So that's really important too. And we'll just move on, if that's okay. So what are the options in terms of treatment? I think a good place to start for everybody is lifestyle. Now, by the time a lot of people, you know, come into the clinic and sit down and have a conversation with us, they've probably implemented a lot of these. So I'm aware of the fact I'm not telling you anything you probably don't already know. But specific to kind of hormonal change, we know in your diet, there are things called phytoestrogens, which are plant-derived estrogens. Things like flaxseed and soy and tofu are really high concentrations of these phytoestrogens. And they have been shown to have quite good benefit for women who are maybe mildly symptomatic. So not the kind of more severe end of the spectrum, but slightly milder symptoms. And they're part of a heart healthy diet anyway. So we know that it will probably have good impact on your long-term health. Now, they're not good enough to treat things like osteoporosis, but if you're someone who has good bone density and you're not keen to start something pharmacological, building those phytoestrogens into your diet on a daily basis could be really helpful. Generally, a heart healthy diet, Mediterranean diet, important too. Getting your cholesterol, your blood pressure checked annually, not smoking, reducing alcohol intake, being aerobically fit. They're all things that are going to set you up for good heart health. Having adequate calcium, and this is more, we're focusing on bone density here. So you want adequate calcium in your diet, about 1,000 milligrams per day. So that's equivalent to, in real life, about 3 or 4 servings of something rich in calcium. Dairy being the obvious source, but also leafy green veg and broccoli and spinach and oily fish and almonds, and Google it. I'm sure there's loads of other sources. So if you've good calcium in your diet, that's great, but you've got to absorb that calcium, and it's vitamin D that helps you absorb calcium. We have a tendency on our latitude in Ireland to be quite vitamin D deficient. And so the general advice is that we think most people probably benefit from a vitamin D supplement. It does not matter what brand or what type. Any vitamin D supplement over the counter daily throughout most of the winter if you can. And then the other part of bone density is to make sure that you've good balance, because if you don't fall over, you're not going to break your hip. Good core strength, so that if you trip or you're going to fall over, you can correct and right yourself. So things like Pilates are really good for that. And weight bearing exercise, the more you pound the streets type thing, if you're out walking or running, or also Pilates, yoga, doing weights, that's all going to help promote bone density, which is what you want. Caffeine, I generally laugh at this because I'm such a caffeine addict and such a huge hypocrite, but reduce your caffeine if you can, reduce alcohol, and obviously other things are just reduce the triggers that, make your symptoms worse, really obvious things. Cognitive behavioral therapy, again, there's actually a wealth of evidence to say that it can be really helpful, but particularly for mood, anxiety, and sleep. There's really good online resources if you're not keen to go and see someone. Better sleep, as if it's as easy as that, but make little changes around sleep hygiene, reducing alcohol and caffeine. Just be conscious of trying to be a bit more precious about your sleep, and in general that probably translates to better health long term. And we have non-hormonal medications. So my clinic in the Rotunda, we see a lot of complex patients who maybe can't, because of medical reasons, go on HRT. And then obviously there's loads of patients who choose not to go on HRT. And thankfully, we do have some medications that are good at treating hot flushes and night sweats. They're not as good as estrogen, but they're not bad. And sometimes a combination of these medications really is what helps someone feel better. In that kind of list of medications, we include antidepressants. Now, people balk when I say that. I think they have such a bad there's stigma, I think, attached to using antidepressants. If you're clinically depressed, antidepressants are helpful, in addition to all the lifestyle changes. Even if you're not depressed, antidepressants, certain types of antidepressants can actually independently or independent of their effect on mood, they reduce hot flushes and night sweats, which I think some people don't know. So we use them in lots of different ways for lots of different reasons, and they have a role and a place here, I think, as part of the conversation. So we'll go on to the next slide, please. Okay, HRT. So combination for most women, it's a combination of estrogen and a second or third hormone, progestogen or maybe testosterone. But the backbone of your HRT is your estrogen. It is the bit that makes you feel better in a nutshell. You get all of your benefit from estrogen. It is what reduces your symptoms and improves bone health and heart health. So there's loads of different ways of doing HRT. This is where it gets complicated. And there's different sort of routes of administration. The timing is really important. So we have what's called a window of opportunity with hormone therapy. And we know that women under 60 and women within 10 years of their last period starting estrogen will see a small reduction in their long-term cardiovascular risk. So that's what that means. So you need to balance up, benefits and risk with every patient. It is highly individualized, and vaginal estrogen, typically little pessaries or cream that you can insert vaginally, they are not hormone therapy. I don't know why. I actually should do a separate slide, but anyway, they're not HRT. They're estrogen, but they're not HRT. They're really safe and they don't impact breast cancer risk. And we should post it to every woman on her 50th birthday. She should open up a card from the government containing her first Vagifem. And I'm being sort of flippant, I know, but it's so treatable and they're so safe. They're over the counter in England. And I just feel a lot of women are scared of them, because if you open up the leaflet that comes with your vaginal estrogen, it says, welcome to your HRT. So you obviously don't care about your breast cancer risk. And then you get this big, horrible, terrifying leaflet, and none of it is true. And there's lobbying going on in the UK at the moment to change that leaflet, because it isn't applicable to the localized estrogen that we use to treat vaginal symptoms. Okay, next slide, please. So if you've had a hysterectomy and you don't have a womb, you take estrogen on its own. If you're someone who still has a womb, or you have a history of endometriosis, then we give you estrogen and a second hormone, progestin. And the reason we include that second hormone, progestin, is to protect your womb. Estrogen will cause thickening of the lining of the womb. That's a risk factor for womb cancer. We protect your womb by giving you that second hormone, progestin. That's called combination HRT. Women who are still having periods or haven't gone a full year with no period, they take cyclical HRT. So you're taking estrogen all the time and the second hormone just for 2 weeks a month. And you're probably going to still see bleeding happening. Women who are postmenopausal, had a year of no bleeding, they go on continuous HRT. Estrogen all the time, progestin all the time. We don't expect you to bleed. I'm not going through the other two because it's a bit too detailed, I think. So we might just move on to the next slide if that's okay. And then one of the big changes we've seen in the last few years is that we've moved away from using tablet form of estrogen. And there is a role for estrogen tablets. They're really convenient. They're safe. Modern estrogen tablets are quite safe. dermal estrogen through your skin is probably a bit safer. So it's not broken down by your liver, so we don't see a change in blood clotting risk. So that's the big difference. So if you're on tablet form of estrogen, we have to warn you that there's a small increase of blood clotting or stroke, but we don't see that with the dermal products. So they are a gel, a patch, or a spray. Everybody, certainly in our practice in our clinic, everybody gets started on the lowest dose, and we titrate you up very slowly. We tend to see less spotting and bleeding with dermal estrogen, we think, but certainly with lower doses. And even really low doses can, for some women, achieve like total symptom control. Even a whiff of estrogen will see some improvement in bone density. So you don't need to be on really high doses. There's Davina, and showing you her different products there. So she has, in the bottom left there, she has her, that's an estrogen patch. Top right is actually testosterone, which we'll come back to. Top left, where she's squeezing, that's her estrogen gel. Move on. So there are different products, but there's a gel, that's a daily application. The top right there, Femiston, that is a tablet that you would take once a day. There's loads of different brands. And the bottom right there, that's an estrogen patch. It comes in different doses, worn on your lower back, your bum, or your tummy, and changed twice a week. And it's waterproof, so you can shower and swim, etc. with that on. Okay, we'll rock on. We do, as I say, prescribe the second hormone if you still have a womb to stop thickening happening. There are combination products. There's a patch that contains 2 hormones. There's a tablet that contains these 2 hormones. Most people end up taking them separately because we prefer that. It gives us a lot more room to kind of play with the 2 hormones separately. So a lot of women will end up on something like a patch or a gel. And then in addition to that, they're using either something by mouth, so a progestogen capsule that they're taking by mouth typically, or maybe a Mirena coil. Women with heavy bleeding, women who need birth control, the Mirena coil, which is a small little T-shaped device inserted into your womb, can stay in there for 5 years to protect your womb, releases this hormone progestin, and that's the progestin part of your HRT then. And we'll move on. Yeah. Interestingly, there's one type of progestin that we prescribe called body identical or micronized progesterone. So we're using it to protect your womb, but this particular type of progestin we think has the least impact on breast cancer risk. And again, that's one of the big game changers that's really happened in the last 20 years. So we're having less impact, we think, on breast density with this progestin, and that translates, we think, to a lower increased risk of breast cancer. And the other thing that's interesting is that this particular progestin seems to be good for things like sleep and anxiety. That's my dog, by the way. Okay, we'll move on. This is just to show you, look, the Women's Health Initiative, massive study, happened in the 90s, published their results in early 2000. I won't go into it, but it was flawed for loads of different reasons. But the media sort of ran with it, and this absolute sort of plummet happened in terms of hormone therapy prescribing. It's really interesting looking back, like we're really only going back to the hormone therapy prescribing we actually had in the 90s. The Rotunda had a huge menopause clinic in the early 90s, and then it got shut down until last year. Anyway, okay, we'll move on. So benefits of hormone therapy, we treat bone density, we have a small impact, we think, positive impact on coronary heart disease. Maybe there's benefit to dementia, but that might be nuanced, and your symptoms improve if nothing else, so that's good. I'm just conscious of time, so we might rattle on to the next slide, Roisin, if that's okay. Risks. Can't really talk about HRT and not talk about breast cancer risk. So women who take estrogen on its own because they don't have a womb, we think that they don't take as much breast cancer risk. In fact, it's arguable that there's any breast cancer risk, but it's probably safer to say, look, there's a risk there, but it's small. Women on combination hormone therapy, it comes down to what progestin, so the thing you're using to protect your womb, what progestin you're on, and for how long you're on your HRT. The longer you're on it, increased risk. And then I know I've said it 10 times already, but the vaginal estrogen, those local pessaries, no breast cancer risk at all. Mammogram screening. So if you're under 50 and you have no family history of breast cancer, you don't need to have a mammogram to start hormone therapy. And all mammogram screening should be whether you're on hormone therapy or not. So it should be from 50 every 2 years as per the national screening program with Breast Check. We'll do early screening for women who need it for other reasons because of family history, not because of HRT. Okay, yeah, skip that. We'll go through. We'll drive straight on if that's okay, because it's basically saying the same thing as this slide, which is we still work off those old numbers from the Women's Health Initiative, believe it or not. And when that data was reanalyzed, this is what they came up with. The group of women who were between 50 and 59 who started HRT in that interval, we'd see about 3 to 5 extra breast cancers, like additional breast cancers, per 1,000 women who took 5 years of HRT. So it's not zero, but it's not big. And it's offset by some benefits. And it's individual. Some women, maybe, you know, they're getting no benefit from their hormone therapy. Perfect bone density, I've no symptoms. You know, then why would you take any additional risk? But for most women, the health benefit we think they get versus this breast cancer risk, certainly up to 5 years use in that category 50 to 59, for most women, they'll get more benefit than risk. Okay, and then just a couple of myth busting. So you can have HRT if you're still having periods. Estrogen through your skin is the lowest risk. Doesn't matter if you have a family history of breast cancer, but you need to be counseled appropriately. But it's not a reason to not take HRT. The estrogen through your skin and the safer progestogens, they're the ones you want to use. We think in younger women, it doesn't have as much impact in breast cancer. So if we're treating perimenopausal symptoms, their breast cancer risk is less impacted. Take it for as long as your benefit outweighs your risk. That's an impossible thing to measure, but that's the advice that we're given. Basically, that means talk to the person who's prescribing for you on an annual basis at least to kind of help figure out where that line is between benefit and risk. And don't forget, there are health benefits as well as risk with HRT. And then just to mention, before I get accused of only talking about HRT, obviously, like we said, there are other plenty of other medications that we can use. Don't forget your screening, cervical screening and mammogram screening and bone density screening and STI screening if you have a new sexual partner. All of those things still really important, and lifestyle really important. You know, all those other things add to what you're doing with hormone therapy, or maybe enough on their own. It depends on the person. But we try and talk about everything and take a holistic approach. I think that's it, Roisin, and I think I'm done. Let me have a look and see are there questions. I hope I didn't go too over time.
What I'll do, Caoimhe, thank you so much. Wow, that was just fascinating and fantastic to get so much of that really good information and the facts in one place. What I really liked about what you were talking about was the fact that we don't talk about it because it's linked to aging, but yet coping with menopause probably starts in our 30s, because if we have better bone density and we're exercising and all of those things, it will help. And I think personally, I've tried to get healthier as I go through it myself. And I think the symptoms reduce a little bit as you try to kind of like eat healthier or get more sleep or whatever. So brilliant. There's a few questions I've grouped together, and I know we have covered HRT, but I'm just going to put them all together because people have asked them. There's a few, like, is HRT the only option to deal with health outcomes? Is it safe? How long do you need to take it for? And when's the optimal time to start? So you've kind of covered that, but maybe just some people came in a bit late.
So yes, it's safe for most people, but like any medication, you need to have a balanced discussion about it. It's not risk-free. So it depends what you mean by safe. But the benefit outweighs the risk for most people with short-term use. Longer term use, so how long you take it for, it really depends on the person. Like you know, some women will stop it after a few years and their symptoms don't come back because their brain has gone through that adaptive process and they don't need it longer, so that's fine. But for other women, they have debilitating symptoms for life. Now that's a small percentage, but they benefit from HRT for life, so it depends on the person. The best time to start it is when you have symptoms. So that doesn't matter if you're 45 or 55. But like, you know, I certainly wouldn't be at 45 thinking I can't start hormone therapy yet because I don't want to use up my 5 years. I wouldn't be, you know, the 5 years, there isn't a 5-year rule, by the way. It's not like we come and knock on your door and take your HRT off you at 5 years. But we know that it becomes a bit more individualized from 5 years on. We can sort of generalize up to that point and say people get more benefit. But that counter doesn't start at all until 50 anyway. So anything under don't need to be as concerned about. And I think if you're symptomatic, treat it. Like if you have symptoms that are affecting your quality of life, do something.
Okay. There's a couple of other specifics. Are there vegetarian or vegan HR treatments?
Oh God, that's a really good question. And I know with the body identical stuff, with the progestogen, I think it's not vegan, and that is an issue. And I think there is an alternative off the top of my head. I don't want to give wrong information, but that's worth it. are alternative options, but I think uterine we typically use probably isn't one.
The other question I have is, how does having the coil in the late 40s affect the overall progression of menopause? I.e., could you be on the other side but not know until the coil is removed?
So it has no impact. So if you put a coil in, that coil, if it's a hormone, there's copper coils which have no hormones, but if you have a coil with a hormone in it and your periods stop, which is the majority of women because of this hormone that it's releasing, this person is right. And I know no more than they do whether or not they're postmenopausal or perimenopausal. We don't know. It doesn't matter though. If they're symptomatic, you treat them. Like, that's the kind of take home. So we don't have to discover, are they perimenopausal or postmenopausal or whatever, it doesn't matter. But it won't affect what their ovaries are doing. So if you have a coil in, your ovaries are going to function away in the background, absolutely irrespective of what your coil is doing. It won't change the progress of anything at all. My four-year-old just joined.
No problem, no problem. It's always good to start early. There's just one question about, advice around HRT and fibroids.
Yep, I can see that there. Yeah. So fibroids, for people who aren't familiar with them, so they're benign growths that happen from either the lining or muscle layer of the womb, and they're really common. And there's kind of a peak incidence through our 40s. So if you go back to my perimenopausal slide, and I was talking about you get these kind of spikes or peaks of estrogen. More estrogen stimulates the lining of the womb. So that's why we see fibroids through our 40s, because we actually get these kind of like big spikes of estrogen, and it promotes the growth of these fibroids. And the incidence is it's probably at least a fifth to a quarter of women over the age of 45, she said, kind of plucking numbers out of the air, but it's in that kind of ballpark, would have fibroids and did an ultrasound for everyone. And they're often asymptomatic. You've no idea that they're there. We find them incidentally with an ultrasound, or big, they can give you a lot of bleeding. So they're one cause of very heavy periods. They're really big, they can give you pressure symptoms. They push on your bladder, or you actually can feel like something is dragging or coming down. The problem with HRT obviously contains estrogen, and so we're going to cause more stimulation to those fibroids. But that's the point of the progestin. And most of the research would show, if we know someone has problematic fibroids, we try and limit their estrogen. So we don't go up to the really high doses. And we try and be very good about saying, look, you need to be very compliant with taking your progestin. And we maybe give you a bit of extra progestin if you need it. So it's just about getting that balance right. But the majority of women with moderate fibroids, it's unaffected by HRT.
Okay, great. Thank you. Another question, can early menopause be brought on by stressful incidents in someone's life?
I'm not familiar with research. Like, I can't quote you statistics around that. I'm not familiar. But I think yes is probably the short answer to that. You have, so all of your reproductive hormonal production is controlled by your hypothalamus. So it speaks to your pituitary, and then your pituitary controls your ovaries, and they produce all the hormones. And your hypothalamus is actually really sensitive to psychological and physical trauma. So women who have like severe abrupt illness, or have bereavement, or women who diet really aggressively very quickly, like a kind of physical trauma almost, they can have, their periods can stop. Now, it's not menopause in that particular situation, but we know that it has on that feedback. And I think you're teetering. So if you're someone in your early to mid 40s and you have something majorly traumatic happen, I think it's very rational to think that it could have an impact on when your ovaries stop functioning properly.
Okay. And just kind of another question here around, menopausal, are menopausal symptoms amplified for people with PCOS, endometriosis, or other menstrual issues?
I think some of them are, And I'm a huge individual. Like, I'm just, conscious of not overgeneralizing.
Yes.
Individualization. So PCOS is polycystic ovarian syndrome, which is really more sort of it's a metabolic issue more than it is anything to do with cysts on your ovaries. And again, it's a spectrum, and some people have no symptoms and some people have physical symptoms, and so it's really individual. But we would, interestingly, some women with polycystic ovarian syndrome, one of the features of this was that they get infrequent periods throughout most of their reproductive life. That's a problem, because that can slightly increase your risk of womb cancer. And they're often women that for the first time in their whole life, they get regular periods in perimenopause. So under that extra stimulation from their brain initially, their ovaries respond by having regular ovulation for the first time ever. So, you know, that's kind of interesting. Whether they're more dramatic in other ways, like hot flushes and mood and emotion, I think probably not would be my answer. Endometriosis is where you see cells that are very similar to what make the lining of your womb outside of your womb. So, you know, a little patch of endometriosis on your ovary or your bowel or other part of your pelvis. And that through perimenopause, that can be problematic. Yeah. Now, again, we've good medicine for that to some degree.
Okay. Is there anything to assist with the increased bladder function and tummy bloating? Another question.
That person needs a conversation with their GP or healthcare provider.
Sure.
That's a bit broad. There's lots of causes for bloating. It can be hormonal dietary. You can develop celiac for the first time ever as you go through perimenopause. Really common, actually, and that causes bloating. What was their first symptom? There was bloating and something else.
Bladder, increased bladder function.
Yeah, vaginal estrogen. Other interventions too, but I would start with some vaginal estrogen.
Oh, okay. Okay. What's your opinion on checking hormone levels through blood tests to determine if you're peri?
They're useless. So they fluctuate so much. You're just checking something that could be different hour to hour and day to day. If they're normal, in a normal range, it does not mean that your symptoms are not perimenopause. And if they come back raised and you think, oh, well, then, you know, I've demonstrated that there's been hormonal change and I'm in perimenopause. Well, we kind of already know that because you're getting symptoms. Otherwise, we wouldn't be doing your bloods. So they're useless. Where they're helpful is younger women, so women under 40 or maybe 45, whose periods have stopped. That's, you know, unusual. They're in this kind of small percentage. And we want to know that their periods have stopped because of menopause and not for some other reason. And so they're women we can measure bloods for. And then the other, like we would do blood tests in the clinic for women at any age, but we're doing them to rule out other causes. There's mimickers of menopause. You know, someone comes in saying, I'm tired and I've put on weight and I'm this, that, and the other, and I'm, you know, my mood isn't great. And they're hypothyroid, like they have an underactive thyroid. It's not hormones at all.
Right.
So we don't want to label something and miss something. So that's where bloods come in.
Cool. Okay, there's a couple of more. I'm just going to take one or two last ones. Someone's talking about they've been through, sorry?
It's rapid fire. Go for it.
Rapid fire. Someone who had endometriosis went through menopause 10 years ago with no problems, but now in the past 18 months find their vasomotor symptoms have begun, and you know, just sweats are worse now as well. So should that have ceased, or what do you think she could do about that?
Yeah, so it depends. When they say they went through menopause 10 years, obviously the period stopped 10 years ago, but that could be for a variety of reasons. Maybe some of the treatments they had for endometriosis. This needs teasing out a little to kind of figure out symptoms. I do think the women who come in saying, I had symptoms, they went away, and now they are back. That warrants investigation. I wouldn't jump to the conclusion, oh, it's just your menopause coming back. Like, that's not really a thing. So I think we do bloods, we look at a full blood count, we look at their thyroid, we look at a chest x-ray if we need to, and look for other things that might, you know, menopause isn't the only thing that can give you hot flushes and night sweats. So that's a discussion with your GP to see other tests.
Okay, and then just two final questions I can see here. One is, how do you get an appointment in the Rotunda Menopause Clinic? And the second one is, if you take nothing and you're over 50, will that impact your health later on?
Okay, so the first one is easy. So your GP would be able to refer you through the electronic referral system that we have, and it's directly to the Menopause Clinic in the Rotunda. There is a direct referral pathway that your GP would be familiar with. You need to be in the catchment area of the Rotunda, which is North Dublin and surrounds. I can't be more specific than that because my job. Your GP would probably know. Okay, so if you take nothing over the age of 50, will that impact your health? Not necessarily. I definitely don't want women to think I should go on HRT to improve my health. Having good exercise, weight-bearing exercise, all the calcium and vitamin D, like all that stuff that we spoke about, your caffeine and your alcohol, and making those interventions probably has more impact on bone density and heart health than HRT does. So I certainly wouldn't think if I don't take HRT, I'm going to have a heart attack and osteoporosis. There are other ways to prevent those things from happening. HRT is just one tool in the tool belt. That's all it is.
Okay. Brilliant. I know there's a couple of questions coming in, and I might just try and see if we can get to them another time, because we're talking about menopause clinic in the West and gaining weight and things like that. I think there's a...
I can answer them really quick.
Sure, yeah, if you have time,
Okay,
because I'm conscious of your time as well.
There's a menopause clinic in the West. There's one based in Galway run by Marina Curran, who I know really well. She's excellent. And again, your GP can refer you. And there's a private clinic run by Cassie McVeigh in Sligo. It's called Vitality Clinic, and she is absolutely brilliant. Yes, I have a private practice. We are based in Dalkey, and it's called Menopause Health. You'll find us at info@menopausehealth.ie. HRT shouldn't cause weight gain. It's considered to be weight neutral, but there's always very, very small percentages that are the yeah, I think that's all of them.
Brilliant. And can I just say again, Caoimhe, that's just been fantastic talk. I think it's been very empowering for women to actually get out and talk about our health. I think it's really useful, and I think people should really talk about it a bit more. It's just, I think, to be honest, it's a privilege to age. The fact that women live much longer, you know, we're all going to go through this. So it's important that we equip ourselves with the information. I do think the vaginal estrogen is a great idea, and it's probably something the trade union movement should lobby for. In terms of every woman getting one at 50, I think that would be a really good idea. So just thank you so much for your time. I really appreciate it. We were delighted. We had so many people on with so many questions. So yeah, thanks very much for your time and all the information. No problem. Technology is, you know, that's just the way it goes. But really appreciate your time on this.
Thanks very much, everyone.
Thanks so much. Take care. See you, everyone. Take care till next time. We'll be back.